Is the doctor-patient relationship in jeopardy? Find out on Medical Economics.
The physician-patient relationship is changing. Some people say it's declining, but I don't agree with that. I think that expectations have changed, and we as physicians, but also patients, need to understand that there are ways to mend these issues.
Is the doctor-patient relationship on life support? Many physicians say trends in the U.S. healthcare system have made primary care more transactional, that the demands of practice make it difficult for physicians to spend enough time with their patients. Appointments are shorter and more rushed. Physicians often find themselves spending more time staring at a computer screen instead of looking their patients in the eye. What can physicians do to reconnect with their patients? Today, I'm joined by Dr. James Underberg to discuss ways to heal this sacred bond. Dr. Underberg, thanks for joining us today. What's your opinion on the state of the physician-patient relationship?
The physician-patient relationship has become altered by the interaction of a variety of other factors that oftentimes provide less time for physicians and patients to speak with one another, and actually time for physicians to listen to patients. There is the computer-based time and electronic medical records. There's difficulty getting into patients getting into doctors' offices. There are issues with doctors getting in touch with patients after they see them. All of this creates barriers between physicians and patients, and there are ways to get around this. And certainly there are practices that are devising methods to get over and through these barriers.
What do you think are the major issues that get in the way?
Well, we've tried to set up procedures and policies such that these become minimized. Time spent with patients should not just be time in front of a computer or the medical record. There should be dedicated time where you're talking to, listening to a patient, and not simply recording and typing. There also should be enough time for patients to be able to interact with you after a visit, find out whether or not there are any new problems or issues that have come from a visit. Also, there should be ways for patients to get in touch with physicians in an easy and simple manner such that they don't feel that they're disconnected or unable to get questions answered or follow up with problems in a timely fashion.
What impact has the decline of this relationship had on patient outcomes?
The physician-patient relationship is changing. Some people say it's declining, but I don't agree with that. I think that expectations have changed, and we as physicians, but also patients, need to understand that there are ways to mend these issues. And so patients being prepared to understand what is going on when they come in for a visit is part of this. But also I think practitioners need to understand that patients often need more. And there are ways to achieve these, sometimes outside of traditional methods.
How has this changed the way you relate with your patients?
One of the interesting things is that practice models are changing right now in the United States. And for a very long time, we had the single, small doctor or small group practices dominating the medical field. What's happened over the last decade or so is that many large institutions have engulfed, bought up, or acquired medical practices, so that certainly in many of the large cities in the United States, the majority of medical care is now a system-based care approach. I think that in some cases there are other opportunities and ways to approach this process, and it doesn't have to be being part of a large system. And so in many of the large cities, we're actually now starting to see movements away from that, and people starting to set up independent practices or restart small group practices. And there are a variety of different ways and models to do this. There's the traditional fee-for-service model. There are membership-based models. There are still the typical insurance-based models, but with lower overhead and lower costs. So there's also a direct patient care model that's developed in the United States. And so I think over the next 10 years or so, we may even see a movement back towards an even distribution of this. And I always tell practitioners, if you're not happy in the setting you're in, or you don't feel that you're delivering care to patients the way you'd like to, there are other methods and models you can look at. And you shouldn't feel that there's only one way to do things.
Managing patients with complex chronic conditions is a huge challenge for primary care physicians. How has your practice model changed the way you treat these patients?
So often patients have more than just one problem, or they may have more complex problems or issues. And in that setting, it's important to remember that there should be someone central to their care. And all too often, that defaults to the patient these days. Even in large system-based practices, oftentimes one hand doesn't talk to the other. And so the key is to come back to the center and make sure that the person doing the internal medicine, the primary care, the family practitioner serves as that central guide to the overall care of the patient. What also seems to get lost more recently is the ability for people to actually speak to one another. So much is done electronically now with sending of records, copies of visits, reports going from one person to the other, and the art of the conversation seems to be lost. And I think key to that is the ability to spend the time talking with colleagues about patients who have more complex care and make sure that everyone is on the same page. And I think that's central to the role of the primary care provider. And whether that's the internist, the family practitioner, a nurse practitioner, a physician assistant, these are important roles that need to be served.
The elephant in the exam room is the EHR. What advice do you have for physicians to better manage this technology?
So part of it is just the physical arrangement of a room. If the electronic health record is computer-based and it's in the same room that a patient is examined in, then there's no place for the physician taking the information to be other than in front of that computer. So trying to find a space to input information that may be separate from where the patient is seen often provides the ability to separate those two functions. So speaking to and talking to a patient, listening to a patient, taking notes, and then while a patient is changing, going back to an electronic health record and inputting the information sounds simple, but it does separate those two functions. And so oftentimes it's about the physical relationship to the patient and how that actually then imparts what's happening from the perspective of the input of information. I try not to recommend any one particular method. What I try to recommend is thinking about different ways to approach this problem, and that not everything has to be done the same way all the time. And if you're uncomfortable and feel that you can't look your patients in the eye while you're listening to them or having a discussion, then something needs to be changed about the arrangement of how you do things. There's always a different way of doing it. You just have to start thinking about it. And all too often, we are told that something must be done a certain way, and so we just do it that way. And I think stepping back and saying, how can we improve on this? The answer may not be immediate, and it may take a while to sort through it. But if we as providers, practitioners, physicians, nurses, don't say, look, this doesn't work for us, then I don't think anyone's going to say, well, here's another way of doing it. We have to be the ones to do that.
Physician burnout is obviously a huge issue. How important do you think improving the physician-patient relationship is to giving physicians more career satisfaction?
I think physicians, to a large extent, view the quality of their work based on how their patients perceive their care, their visits, and everything that has to do with the interaction with that particular physician. And so anything that improves the quality of those interactions, I think improves the quality of the physician time and well-being. That's independent from other things that we know impact physician burnout, such as the stress of charting and billing and volume of patient visits and additional duties that are assigned to physicians independent of their patient care. So there's no one single answer to addressing physician burnout, but feeling better about your visits and the care you're providing is certainly one of the key components of addressing this problem.
What do you think needs to change in the healthcare system to give physicians more time with their patients?
I think to a large extent, physicians often feel that care is being dictated to them and often don't see other options as being attainable. And whether someone is employed, works in a large system, works in a large group, or is self-employed, there's always the opportunity to rethink how you're doing things and make proposals, suggestions, and changes. Some of them are very simple and can be instituted by yourself without anyone else signing off on it. Others may require a lot more complex interventions before change happens. But if we don't think about making these changes, they will never happen. And so the first step is trying to at least imagine or reimagine how we can improve on what we're doing, and then move forward.